Well, good morning, and again, thank you to Jim and his team, and thanks to all of you for braving the weather. I really appreciate it. And I'm going to kind of walk through about a half an hour worth of slides, and then happy to have a conversation on my favorite topic. All right. Okay, for those of you who are not familiar with HANYS, HANYS is a 501c6 trade association representing all the hospitals across the state of New York. And our mission is up there to advance the health of individuals through representation, service, and leadership. And that, I put that up there just because that is our guiding star, and certainly will influence my remarks today. And again, for those who don't know me, I've been at HANYS as the CEO for 2 years, a little over 2 years now. And as Jim said, I started my career as a registered nurse, working in the emergency room and ICU for a little bit more than 10 years, and then kind of morphed into policy and law from there. We have a lot to talk about in 2019. Certainly Singlepayer will be part of that. And I think as part of that conversation around Singlepayer, I hope that, and we'll talk about this later on this morning, but I hope as part of that conversation we talk not just about whether or not to publicly finance healthcare, but to have a deeper and a richer conversation around what are we actually financing, and is it meeting the needs of 19 million New Yorkers, and if what we're going to wind up financing, is it growing faster than our ability to afford it? So those are just some of the questions I think we'll touch on today. I'm going to do, again, I could talk about healthcare reform and for a long, long time. So I feel like I'm giving you kind of the Cliff Notes version, and I'm going to do a past, present, and future look as we walk through some of the issues. First, in looking at the past, certainly you want to learn from what others have done. Don't repeat mistakes, but also look at what works and try to replicate that. And then, you know, in my world, I think healthcare reform is happening in all 50 states 365 days a year, but particular to public financing, about 11 states have looked at public financing in one way, shape, or form. Just most recently in California, the Senate there passed Healthy California, had a Democratic senator, a Democratic governor, a Democratic Senate, and a House. And it failed in the Assembly largely because there were a lot of other barriers to it, but one was the $400 billion price tag. And similarly in Colorado, it was a ballot initiative. It failed by 80 to 20 because of a lot of opposition, but also I think the state tax increase was a major barrier there. I'm most familiar, obviously, with Vermont's single-payer experience. I lived in Vermont from 2001 until 2016, certainly when Act 48 was signed into law in May of 2011. And Act 48 passed just after Governor Shumlin was elected. He ran on single-payer, and he entered into a veto-proof Democratic Senate and a Democratic Assembly. So it certainly was going to pass no matter what. It's also important to remember that Act 48 passed on the heels of the Affordable Care Act. And the bill itself actually, in addition to establishing studies and establishing a 5-member Green Mountain Care Board that was designed to kind of oversee the construction of single-payer in Vermont, it actually built a lot and took advantage of many aspects of the Affordable Care Act. So some lessons learned, and again, just at a high level. First lesson is don't count your savings before they hatch. And as part of the initial fervor around single-payer in Vermont was this idea that that administrative savings, once you had a single-payer system, administrative savings would just materialize, that healthcare would be so much less expensive because there'd be so many administrative savings. And as it turned out not to be the case, and there are lots of reasons why. One is healthcare is transaction-based. We have many transactions, billions of transactions a year, and the payment system is basically based on that transaction-based system called a fee-for-service system. And from a provider perspective, even though theoretically if there was a single payer and you didn't have to submit a bill anymore, you still had to record the encounter, you still had a lot of compliance obligations that you had to maintain. And so therefore, from a provider perspective, there really was not a huge reduction in administrative saving or in administrative waste. As one of my hospital CEOs in Vermont said to me at one point, it's not like magic, it's more like pick and shovel work to try to figure out what administrative waste you can actually wind up getting rid of. And the second lesson is single anything is elusive. And again, related to item number one, where you don't want to count your savings before they hatch, the whole idea of a single payer, even in a tiny little state like Vermont, was very elusive. As it turned out, it was more like fewer payer. And again, Vermont is certainly not New York, and in Vermont there were 3 major commercial payers, with Blue Cross being by far the most major payer. And so again, even if you consolidated payers or got rid of the payers, there really weren't that many commercial payers in Vermont to begin with. And the other item that was discovered during one of the studies is that 1 in 5 Vermonters doesn't even get their care in Vermont. So having the complexity of the people migrating in, Vermonters migrating out to other states, and non-Vermonters migrating into Vermont was a factor that hindered administrative savings and the whole idea of a true single payer. And again, imagine New York with the millions of people going in and out of New York every day and thinking about whether or not you'd be able to achieve actual administrative simplification. The other single anything that's important to recognize is their benefit package. And the Green Mountain Care Board was in charge of creating the benefit package. And because many Vermonters were very concerned about making sure that the coverage was comprehensive, they ultimately landed on a benefit package that had a 94% actuarial value. Now, for those of you who are familiar with the exchange, you know that the platinum products are 90% actuarial value. And even at 94%, there were employers and employees that had 0% out of pocket for their benefit structure, wanted a carve out. And so the lower you wound up going to, the 94% AV at the end of the day turned out to be contributing majorly to the unaffordability of Vermont's single payer plan ultimately. But going below 94 would mean that more and more Vermonters wanted a carve out of that single payer benefit. So it turned out to be very difficult to maintain unity around any aspect of single payer. Workforce is our foundation, and again, as a caregiver, but certainly we talk a lot about financial numbers, taxes. Again, that tended to predominate in Vermont, but the reality around how do you actually make it work, and certainly, you know, another lesson is the devil's in the details, which is a saying I'm sure you're familiar with. The reality is that healthcare is about people taking care of people. And at the physician level, we certainly needed physicians, and one of the challenges that Vermont is still facing today is really how to incentivize, recruit, and retain enough primary care physicians in order to make sure that people are getting the right care at the right time, at the right setting, in settings that are helping them not go to the hospital, not be admitted to the hospital, and not be readmitted to the hospital. So physicians were central, primary care physicians were central to the scheme, and they were underpaid. And so the question, and a problem that Vermont still has not solved, is really how do you recruit and retain enough primary care physicians, incentivize them, and then how do you help them to be clinical leaders? Because you are actually, again, along the lines of not what are you publicly financing, you want to create a healthcare system that is keeping people out of the high-cost settings, but at the same time providing appropriate access and providing good quality care in those community-based and outpatient settings. So you need clinical leadership in order to redesign how that care is delivered. On the nursing front, again, you need workers. The whole idea around cost containment in Vermont was to put all hospitals on global budgets, which was something that we were certainly considering. But when you looked at restrained growth in global budgets over time, we wound up anticipating that there would be a workforce retention issue if you were not able to give workers pay raises. And again, just from a budget perspective, approximately 2/3 of hospitals' budgets are related to payroll, and for nursing homes and home health agencies, that's even higher. It's around 80%. Change happens at the speed of trust. And again, as the lesson here is around how you build trust in a dynamic effort that is continuing to morph as it moves forward. And in Vermont, again, as I said, the Act 48 was built in large part on the Affordable Care Act. And one of the things that Vermont did in 2014 was to create their own health exchange, and much like the New York State of Health. And the idea there, which seemed like a good idea at the time, was to build the exchange, build the website, build the interfaces, and that then, once they were able to switch over to a publicly financed healthcare system, they would already have the interface for Vermonters to enroll, to establish their residency, etc. And so, but it was a disaster. It never worked, and it was over budget, and there was just a million different problems with the exchange. That really, I think, dogged the governor. It certainly dogged the legislature. And then as after the elections happened in 2014, the popularity around single payer went from greater than 70% in the public to just about half. And it was in large part because of the failures of the exchange. It made many people very nervous that if the state couldn't run an exchange, how could they run a single payer system? And so after all of that is my last lesson, which is timing is everything. So after the election in November of 2014, when popularity for single payer was at its lowest point, it had been about 3 years, the population was still largely confused about what was going to wind up happening. And then the last economic report came after, right around the time of the November 14th election. So Peter Shumlin won, he got reelected barely, and afterwards came the economic report that showed that businesses would have an 11.5% increased corporate tax, and the state income tax would rise by 9.5%. And in that context of the health exchange failure and barely squeaking by with an election and the 50% popularity around single payer, the governor pulled the plug on the effort. And this is what happened. This is actually a picture of the burnt toast that was delivered to his door the next morning by the advocates. They were furious at him. He wound up never recovering politically, and a couple of months later decided that he was not going to run for re-election. But again, it was a surprise, I think, for many who had been hoping that they would continue on. So bottom line, it's a journey. It is whether or not you are trying to move anywhere toward a goal with intention. It is not, it's not magic. It's a lot of hard work. It requires data, perseverance, alignment, collaboration, you name it, and certainly a lot of time. So let's talk about New York's journey. And again, I think one of my favorite authors is Dr. Atul Gawande, who I think many of you have probably heard. And he wrote an article that said you can get here, you can get there from here. And his point was you have to have a starting point. And so looking at New York and where we are today is certainly our starting point. And we have a lot of positive things happening. Certainly, Lots of efforts around the state, and again, I feel like I'm giving you the very high level, but lots of efforts around the state to improve access to care, particularly in the outpatient and the community level. And a lot of efforts around switching over from a fee-for-service system to a value-based system. And again, I think many of you are familiar with the Disruptive effort, which is a federal-state effort that was born out of the Medicare redesign team. And we've leveraged billions of dollars to help develop that community infrastructure, much along the lines of what Vermont had a state innovation model grant along the same lines, and they did exactly the same things. Identify, help to connect people, providers remotely through HIT, develop the electronic health records, help to identify high-risk individuals in a community, and build teams of care around them. And it's the same exact thing. Why it doesn't want to work. There we go. Another positive aspect is, and a key fact here, is that 95% of New Yorkers have coverage. Again, New York, like Vermont, has been one of the states that has really taken advantage of the Affordable Care Act, and unlike Vermont, the exchange has been extremely successful. Along with the Essential Plan, we have 95% coverage. Now granted, in a state the size of New York, that's still 1 million people who lack health care coverage. But a question in the conversation for 2019 might be, how do we cover those 5% of individuals, and what would it take to provide coverage to them? Sorry, I don't think this is working. Maybe it's the battery. Another area of improvement is that Vermont recently was named, according to America's Health Rankings, that they were the most improved in improving their overall health rankings more than any other state in the last 5 years. Again, this is based on a lot of data: smoking cessation, immunizations, hospital improvements in critical areas, and mortality due to cancer, among other things. Again, it's no accident, and that's why we did that ad, is that it's reflective of a lot of effort across the state to make healthcare better. The whole idea around healthcare reform is, how do you improve the value proposition? How do you improve care, improve access to care, improve quality, while you're reducing health spending growth over time? That is the entire value proposition, and this is a good example that we are making progress on that journey. And again, more of that in terms of quality and patient safety. It would be easy to reduce costs if you didn't have to worry about anything else. But again, we want to make sure that we're trying to work toward the triple aim of improving health while we're, and access and quality while we're reducing health spending growth. And this is a project that HANYS has been working on with Greater New York and the Centers for Medicare and Medicaid Services for the last 5 years to work on very specific things to improve hospital safety, such as surgical site infection, reducing ventilator-acquired pneumonia, and things like that. And we've been able to make improvement in 7 areas and save money. So again, a good sign. And then on cost, and this is all on the state has been successful at reducing per capita costs. Now, enrollment in Medicaid has increased from 4.3 to 6.7 million enrollees, again, largely due to the Affordable Care Act, but the per capita health spending is now at a lower level than it was in 2003. That is good progress. And again, there are lots of other attributes around our healthcare system. We have some of the best academic medical centers in the world. We have small critical access hospitals that sit on the border of Canada that are the economic center and the gem of their communities. We have many community-based providers that serve immigrants and other needy populations, from from Manhattan to Malone and Brooklyn and all across the state. So we have a lot of positive infrastructure attributes. Another attribute I just wanted to point out here, again, that leads us to looking toward the future, a great asset is we train almost twice as many residents a year than any other state in the country, including California. 16,000 residents a year. That's a tremendous asset that we ought to think about. Again, as I said before, if workforce is our foundation and we need clinical leadership, we have it right here, and we have tremendous talent right here to help us to think through how do we figure out the path to improving care while we're reducing health spending growth over time. So now for the uncomfortable truths, I guess, as we decided to call them. And there are many of them. Again, I'm not going to address all of them, and this is not a complete list, but this just gives you a sense of some of the things that are actually driving up healthcare spending. And again, the reality is we talk a lot about affordability, and I think one of the things that I want you to remember is that affordability, or what I call unaffordability, exists at all levels. It exists at the individual level, it exists at the business level, the taxpayer level, and the state and the federal government level. And I'm going to talk a little bit about that. But some of what I'm going to talk about right now is really part of what is driving unaffordability at all levels. The big one is what we call the silver tsunami, and you know, the aging population. I'm part of it, part of that baby boomers. We're going to have, in New York, 1 million more people over the age of 60 in just 12 years. And again, we are mirroring what is happening at the national level. Like it or not, it's not a question of whether or not people will use healthcare services. It's how much and how many over what period of time. And certainly elderly people use more healthcare services. It's just a fact of life. The second issue is chronic disease. And in addition, and I just use this again, this is just obesity, but you could take diabetes, you could take Alzheimer, you could take cancer. There are many age-related, but also general population-related illnesses and lifetime conditions that drive up medical spending. It's actually quite predictable, but it's on the rise for many, many types of conditions and diseases. This is just an example in terms of looking at Medicaid. Many of you are familiar with this. It shows that the orange and the green at the bottom are the aged and disabled. In terms of enrollment, they're low, but in terms of spending, they're high. And again, this is just for Medicaid, but what I was talking about before is true no matter who the payer is. Another example is the opioid epidemic. And this is just reflective, I think, of a major issue that we don't have a handle on is mental health and substance abuse issues. Mental health and substance abuse issues are either the primary or the secondary inpatient discharge diagnosis for 45% of patients who seek hospital care. It's a huge factor in health spending, in addition to, I would say, drug prices as well is another issue. Certainly, last but not least, is what we are calling now the have and have-nots, or the issue of poverty. The poverty rate in New York State is 14%. That means 14%, or 1 out of 7 people, live at 100% of the federal poverty level or less. I'm forgetting the numbers. I had them in my head earlier, but the living at the poverty level means that you live on $243 a week. And a family of 4 at the poverty level lives annually at about $45,000. To add to that, people at 200% of the federal poverty level add 12% to that. So you have, getting close to a third of people at 200% of the federal poverty or less. And if you, and you know that the Affordable Care Act offers subsidies at 400% or below, 57% of New Yorkers live at or below 400% of the federal poverty level. So that's 6 out of 10 people who either have very little discretionary income or no discretionary income. So it's a serious fact of life, which helps to explain the cost shift. And all I really want to say here about that is that all the innovation, all of the infrastructure that you see in New York's healthcare system across the spectrum comes from 40% of the population. So when you think about public financing, it's that dynamic of the of where the dollars will wind up going and who they're coming from is something to consider. So I'm going to transition. So that's all of what's driving unaffordability. I'm going to talk a little bit about the magnitude of the unaffordability at the state and the federal level. So first, just to talk about the debt. And again, you hear a lot about the debt in the news and you know, on your smartphones. The federal debt is nothing new. I think what's new about the federal debt is the country used to go into debt usually when they had a war and had a reason to borrow money for a particular purpose, but then they would pay that debt down. What's happening now is we have a borrowing problem, we have a spending problem, and we are continuing to, the debt is continuing to increase because we have sustained deficits every year, year after year after year. And we are in that situation now. We have about $800 billion gap, excuse me, in 2018 now, where we're taking in $800 billion less than we're actually projected to spend. But that gap is projected to be steady and increase over the next decade. The tax cut bill that was passed last year was intended to spur economic growth so that there would be more corporate tax and payroll tax revenue. But again, that's not exactly what's predicted here, and that certainly hasn't been, we haven't seen that yet. So what this does, and this is just a simple pie chart of the federal government, and so what this does to entitlement programs, particularly Medicare and Medicaid, is it puts pressure on those entitlement programs. If you look at the big red piece of pie, that's the entire federal government. If you look at defense as 16 as the black, the interest on the debt, we have to pay the interest on the debt, and that piece is growing. The higher the debt goes, the bigger the payment of the interest on the debt. And you have Social Security, which is actually right now is still running a surplus and helps to plug the funding gaps for other programs. But you have Medicare and Medicaid spending. And that's why you have very little flexibility in all the other pieces of the pie. And that's why there's tremendous pressure on Medicare and Medicaid to slow the spending growth, because as healthcare spending growth continues to exceed general economic growth, Medicare and Medicaid are pushing out while the other pieces of pie are pushing in. And again, other than Medicare, the state budget pie looks very similar, or at least it has the same dynamic. So the bottom line is, and this is important to remember, is that health spending growth, no matter what we do, no matter what the solution, large or small, is going to exceed general economic growth for the short and medium term. It is, in my opinion, something to be managed and something to be recognized, and I think most importantly, it's something for the public to understand. Again, thinking about the ideas and the idea around a single payer solution or a free market solution, if you want to look at the other end of the ideological spectrum, is the promise is that it's a quick and easy and you know, a magical fix, and it's not. There are none. In fact, even you know, I think when President Obama passed the Affordable Care Act, in my opinion, I think one of the biggest challenges, problems that he encountered was that he wasn't realistic in letting the American public know that it wasn't going to be a quick fix, and he was subject to a lot of political backlash because it didn't materialize immediately, and it was very complicated. You know, like who knew it could be so complicated? So, but that is the reality, and again, I think it's something that the public really needs to understand, that there is no quick or easy fix. As we're going into the future, there are other things to think about, and I think a big one, you know, healthcare would be very, very difficult to solve if we could make everything freeze in time for 5 years. So if we could hold everything the same and then try to, you know, jigger a solution, maybe we'd get somewhere. But things are changing even faster every single day. I'm going to go back to the B2B. There we go. So B2B to B2C, so business to business, business to consumer. Healthcare is becoming a much more dispersed infrastructure. So you're starting to see, and again, I think it's neither good nor bad, it just is what is happening. It used to be what we would call an enterprise-centric system, and it still largely is today, where hospitals would deal with insurance plans would deal with home health agencies, and it was really, the consumer was really tangential in that equation. And now that is changing. Consumers have more financial skin in the game, they are paying attention, they're buying out of pocket for certain tests and procedures, and they are very much more a part of the equation. And so I think that is a major factor that's happening in our industry today. A big one is technology, and again, I'm not a technological person, and we've certainly been spending a lot of time at HANYS thinking about the impact of technology. And there's lots to it. There's wearables, there's AI, there's big data. And when you think about us as users and us as consumers, I mean, think about your cell phone, and I have teenagers. Think about your teenagers 10 years from now using their cell phone. They're going to be getting most of their healthcare on their phone. Telemedicine is going to be commonplace in both urban areas and rural areas. And we met recently with telecommunications executives in downstate, and they told us that within 5 years, in many parts of Long Island, you would be able to have an ICU in your house. They would have the technological capacity to be able to have an ICU in your home. So think about that in terms of the drive to lower prices, the drive to maintain market share, to have consumers get the care that they need. If innovation can really change how we're actually delivering care in those dramatic ways, how do we anticipate for that? How would the state regulate in that environment? How would they regulate healthcare if most of what we were getting was over our phones? So those are just some of the technology-related questions that I think we have to think about, because it is already changing our healthcare system, and I think we need to much better understand what is the impact of technology on us as consumers, but also as payers, as providers, and as the state delivering healthcare. In addition, we have what we call disruptive market changes. Again, neither good nor bad, it just is. I think part of the disruptive market changes are happening, frankly, out of impatience, that they are, like Jeff Bezos and Warren Buffett and JP Morgan are looking for a new way to try to reinvent healthcare. It's not dissimilar from the notion of single payer. It's a way like, how do we figure out all this stuff that gets packaged into healthcare and figure out a way to make it more effective and cheaper. And so that's what's certainly happening. Again, you've seen too that they've gone largely underground in that they're looking to, under the leadership of Dr. Atul Gawande, to take the time that they need to figure out what they're going to wind up doing. So they started that, and then they haven't said much since then. Another market change is we're seeing a lot of, in addition to the disbursement into a a business to consumer environment, we're seeing lots of vertical consolidation in the market, particularly in the payer market here. And this was just last week. I think it was in the Wall Street Journal. A lot of vertical integration between health plans and retail pharmacies and other organizations to try to figure out a new way to deliver care. And I think what's happening here in the CVS Aetna situation is that they are looking at non-medical environments in which to provide services to patients needing primary care services. And think about the last time you went to see a primary care doctor. Probably, the doctor may not have needed to even lay hands on you. Maybe you just went to get a prescription. Maybe you just went to get some education or some context or some reassurance.
it's those types of primary care encounters that are perhaps going to be on a new path where you might, in a few years, go into a kiosk in CVS and talk to a primary care physician. May not be your own physician, but it may be online, and you may be able to get exactly what you need and get your prescription filled and do it at your CVS. One thing about a distributed healthcare environment is that 75% of Americans live within 3 miles of a CVS. So you couldn't think I wouldn't talk about politics, of course. Again, in this context, looking forward, we could not have a more divided country, I don't think, sadly. But it has an impact on healthcare when we're thinking about what do we do as a country, what do we do as a state to try to make our healthcare system more affordable, but yet meet the needs of our 19 million New Yorkers. And at the national level, Bernie Sanders, the senator, of course, from Vermont, has introduced a Medicare for All bill for the past 5 or 6 years. Typically in the Senate, it would get no co-sponsors, and really no one would even really talk about it. This year it has 16 Senate co-sponsors, including Senator Gillibrand, Cory Booker, Elizabeth Warren, and other contenders that are already out there for the 2020 Democratic nomination. So you kind of see that happening. And as we look at 2020, you really are already starting to see that on the Democratic side, you're going to look, and it was already in play with Speaker Pelosi, where Brian Higgins from Buffalo wanted to make sure that there was going to be a vote on a Medicare option as part of getting his vote for her for Speaker. But you're starting to see Democrats veer over to the left, and you've already got the GOP over on the right, but there's nothing in the middle. And again, here in New York, we certainly will have a conversation around the New York Health Act with Chairman Gottfried as chair of the Assembly Healthcare Committee. And again, it's a broader conversation is what I would propose. And certainly even the New York Health Act, as we were talking about before in terms of the elderly, it doesn't cover community-based care or long-term care services. So I don't have a crystal ball, but I do think that in New York we will come back to many of these lessons. Again, because it's not just about, are we going to publicly finance healthcare or not? It's much more complicated. It's what are we financing? Will it meet the needs of our 19 million New Yorkers? And are we going to just build another mousetrap that's growing at 4 to 5%? And again, I'm sure many of you have read the RAND report. Depending on how healthcare growth would continue year over year, I think at 4% growth, politicians would have to raise taxes by $7 billion a year. And again, that's a cultural and political reality that I think many politicians are not necessarily prepared for. And if the mousetrap that was built was growing at faster than 4%, well then the funding would have to come from taxpayers. And again, that's a challenge. We're funding that growth now, but in different ways. But again, it's that political context. So how do we have a constructive conversation? Again, if you haven't already picked it up from me, broaden the narrative, which is one of my key messages. And facts matter, having a fact-based dialogue. And again, in particular for me, is around the needs of our patients, the needs of our aging population, and the reality that there is no quick or easy fix around reducing health spending growth. It certainly means we have to try, and there are many things that are either in place or that we can be doing to try to reduce health spending growth, but it's not something that's going to happen in 2 or 3 years. And again, I think talking to one another and having a respectful dialogue is important as well. Second item is coalesce around some core goals. And again, from my perspective, I think looking at affordability at all levels is critically important. in particular, focusing on long-term care. Again, I said it's not part of the New York Health Act. As we look at, and it's not just medical care, as we look at the millions of New Yorkers that we have that are going to be reaching age 60 and beyond, we have to look at issues like housing. Are they aging safely at home? What can we do to keep people in their homes so that they are not unnecessarily going to the hospital or being readmitted after a hospitalization? Supporting caregivers, and again, not just on the level of we certainly need physicians, we need nurses, but we need personal care attendants. We need the right type of caregiver for patients in terms of whether or not we're caring for them in a medical setting or all in the community setting or in a non-medical setting, and really taking a look at the appropriate role and making sure that we have caregivers who know how to use technology, for example. That is going to be, again, more commonplace and something that we have to make sure that our caregivers understand how to use it. In addition, as we look at the legacy costs that hospitals have and other healthcare providers, such as providing retirement benefits and health benefits for their employees, as we have new young people coming into the workforce, are there different ways that they want to work? Can they be an asset to us in helping to provide care remotely, for example, or working as independent contractors if that's what they like to do? So I think we can look more creatively about some workforce issues. The second goal would be improving individual and population health, and here are just some examples. Obvious one is coverage, and again, where we come from, we think the more people have coverage, the better chance you have at helping people improve their health in the short and the long term. And coverage is also important for, in the aggregate, for improving population health. Better information, as consumers have more financial skin in the game, getting them better information, but also getting providers better information. We are a data-driven industry, and we still, I think, have a lot to learn in terms of predictive data, genomics, and other types of information that can help us both not only cure disease, such as Alzheimer's or cancer, but also help to make sure that if there are solutions to be had, that we can use the internet and others to help spread that information out into the public in better and creative ways. And then certainly supporting innovation. And again, I've talked a lot about that, but we have to do our best to try to look toward the future to see how healthcare is changing. And I think rather than try to make things stay the same, I think we have to anticipate that the world is changing very, very quickly, and we have to embrace that. And on the issue of socioeconomic conditions, look at the disparities of healthcare. And I think we're starting to do that now, and I think New York is actually making great strides in looking at some of the socioeconomic factors in communities that are contributing to high medical spending growth. And I feel like we're in kindergarten on that. I think there's a lot of value in looking at some of those broader conditions that are impacting health spending growth and trying to address those. And if you look at what other countries are doing, they spend a lot on public health and less on medical care, and we're kind of the opposite. So I think we can kind of even that out a little bit and really take a broader look at how we are reducing, how we can creatively reduce medical spending growth by looking at how we're spending our public health dollars. Switching gears here a little bit, I have a 47-member board, hospital leaders across the state of New York. And in an effort to try to prepare for the future, rather than predict the future, we took our board on through a scenario planning process. And the value of the scenario planning process, again, was not so much to predict the future, but to try to prepare for the future, no matter how the future unfolded. And it allowed us to first go out to the long term and then work our way back into the present day. And I think one of the values that it has had for us at HANYS, but I think also for our board, is that we are now not, and certainly at HANYS, we are not looking just at healthcare. We certainly, as a trade association, we have been looking at Medicare, Medicaid, commercial payers, and looking at the healthcare industry very specifically. But now we are looking at that, I would call that ring around it, looking at those disruptive innovators, looking at technology, looking at social determinants of health, and looking broader around healthcare in a way to try to think about what are the things that we're seeing in our world today, what are the drivers and the forces in our world today that are going to be impacting the future, not in a predictive sense, but again, just to be more prepared around them. And our board selected the have and have-nots, the poverty, in other words, and the relative worsening or improvement in poverty and technology as the two most impactful drivers in our world today. And again, use this process to try to help us to think a little bit broader around about the world around healthcare in a way to be better prepared for the future. And I think that as we think about 2019, my recommendation is that we also take, not necessarily go through scenario planning, but we take that broader view to look not just at what's happening in healthcare and get lost in the data, because you certainly can, but look beyond that and look at what is happening, for example, to consumers. How are consumers shopping? What do we want? What is changing in healthcare related to convenience? How is data changing? And you can't open the paper and see something that is not a signal of the future and a signal of how things are changing. And again, my recommendation is that we embrace that and think about how do we think more creatively about the future we want to create, and again, design a healthcare system that moves us forward in that regard. And so again, it's, I think we all have agreement that we want to achieve the triple aim of better health, better care, and lower costs. It's really how we get there. And I heard a saying recently that, that really summed it up for me, is that if you want to go fast, go alone. But if you want to go far, go together. So with that, thank you very much.
Would you like me to moderate the questions?
No, I don't. No, I can moderate them. Sure. Go ahead.
I think your comment about managing expectations and the rising cost of healthcare over time far exceeding inflation is incredibly important. And I think it's odd where we're sitting today. I actually have a report on my desk commissioned by New York State government about rising healthcare costs. And it's a very nice report. It goes on at length with all kinds of charts and graphs about rising healthcare costs, use of the emergency room in an inappropriate fashion, how these costs are all unsustainable and have to be addressed, on and on. You could think it was written today. Oddly enough, it doesn't have a date on it, but if you look at the transmittal letter, it's very telling because it begins, "Dear Governor Rockefeller." And it's the same issues.
Yep, I've come across a few of those reports myself. I was either clear or unclear.
I'll ask a question. May I ask a question?
Yeah, sure, of course.
I thought that was a wonderful presentation, Bea. Thank you. The Vermont, coming from government on the inside now here, we often get lost in this discussion versus single payer versus what problem are you actually trying to solve? And in New York, it is different than some other states. We have an expansive ACA program with Medicaid expansion, other things. When you were in Vermont, what was the political dynamic of what they were trying to solve? Why were they pushing for single payer? I think often that's a proxy to the end point that you were getting at, which is it's more of a political interaction than it is a healthcare discussion, which I think is the worst place to be in a healthcare discussion. But what in Vermont were they trying to solve with some of the things that you were discussing today?
Well, I think they were trying to solve universal coverage, and it was just more of the Commonwealth of Vermont. They felt that it was really around universal coverage and fairness and equity, that the public financing would mean that everyone paid what they could People who could pay more would pay more, and people who couldn't afford to pay wouldn't pay. And then don't count the savings before they hatch. There was a lot of belief that by creating a single payer system, you would make it much simpler. It would be very easy, and it would be much, much less expensive. And so the idea was that it would create affordability, that public financing alone would create affordability was one of the myths that was very, very strong in Vermont. Yes.
Hi. Could you talk a little bit about, you talked about people at 400% poverty level and they're eligible for subsidies. What about somebody that's at 401% or 402%? And I'll give you a real example, because I assume most people in this room have employer-based health care. And if you travel around the world, you know that's mostly not the case. But in my own situation, I have a sister who is above the 400%, and her health care costs through the exchange in Connecticut, a silver plan, are $34,000 a year. That's her premium. And her family deductible is $13,000. Hardly affordable.
Right.
Could you speak to that?
Well, I mean, I think you just did. I think that there is everything in healthcare is very formula driven, and sometimes there's a transition and sometimes there's a cliff. And I think above 400% of the federal poverty level, you are out. So there is that cliff, and I think that is one of the reasons, again, why whether you agree with it or not, I happen to not agree with it, why the Trump administration extended the short-term plans that don't have to comply with the Affordable Care Act to try to create affordability for exactly that population, those who purchase on the exchange who are above the 400%, because I think the average health plan now is $27,000 a year. I mean, it's extremely expensive. Imagine buying a car every year. I mean, and I'm sure it's true here in New York, but when I was in Vermont, people would come up to me and say, I pay more for my health insurance than I do for my mortgage, and I'm sure that's true today. So the unaffordability is very, very real. And again, it's not. I don't say to speak to the unaffordability as if it's just something we all have to live with. I don't say it in that regard. I say that it's something that people need to understand, but we absolutely have to do something. We have to work to do something about it, but we have to recognize that if we try to create a health plan that has skimpy benefits but a low price tag to try to help your sister, that you're not solving the unaffordability problem.
But just one follow-up to that. But if you go to France or you go to Canada, there are a lot of misnomers in this country about the shortcomings of those plans. But if you talk to people, you get a totally different impression. I'll give you a quick example. Because I like to talk to people. But I was in France and I was in a cafe, and there was a waitress there, and she looked pretty happy. And I started to talk to her about health insurance, which I'm sure she didn't expect. She expected me to order food. But I asked her, I said, what do you do for health care? Do you worry about it? And she looked at me. She was very puzzled. And she said, I don't understand the question. She said, of course we don't worry about health care. And one of the things we do in this country, I think, some of it is reality-based, some of it is cultural, is we talk about the increase in taxes. Let's go back to my sister. If we had a system like they do in France or like they do in Canada, her taxes would not go up $34,000 a year. It just wouldn't happen. Plus the family deductible. And so I think that we need to take a closer look at reality. And if you're a small business owner, your taxes would not go up by the amount of the premiums you currently pay under our existing system. So why can't we have an informed discussion about those realities?
Well, I absolutely agree with you. I think we should have an informed conversation. I think as the saying goes, culture eats strategy for lunch every day. And I think the cultural expectations of France are very different than where we are today in our country. And when when I say journey, I really mean that you have to try to be intentional about where you want to get to, but be flexible on how you get there. And two stories, but one, Vermont is now the second state in the country that has an all-payer system. Again, Vermont is not New York, so I get that, but a very small state. But what happened after single payer failed is they didn't give up. They decided, well, we're gonna try it in a different way. And again, they're not done. They have 122,000 of the 650,000 Vermonters under a total cost of care payment methodology, but that's actually a major experiment by any standards across the country in terms of evolving into total cost of care and using deploying clinical leadership to help to really manage the high cost, high needs individuals in a way that improves the quality of their care and reduces their medical spending over time. So, but that's part of that intentional journey, and they are changing over time, and it's been now more than 10 years, the culture of Vermonters who wanted to make sure they had their own doctor and that nothing changed for them. And so that's changing gradually over time. And I think that I think that New York can do the same thing. It's not going to be a 2, 3, 4, or 5 year journey, but I think that there's a lot, and my point about New York is it's a big state. There are a lot of arrows that are moving in the right direction, and I think that we can continue to build on those in a way that is beneficial over time. Whether or not the culture changes, and the political culture would have to change as well. As I said, for politicians to get their mind around what would the political structure look like in New York for them to have a publicly financed healthcare where they have to raise taxes every year. That's not the environment we live in today at all. Even if it was $1 billion, it would be a very tough sell. And it was in Vermont as well. Yes.
Let me go to that, because that question, I mean, your sister's a great example. So the frustration is you would like to have, you didn't talk about the system in the suburbs of Paris. You talked about a national system. So now the question is, what would the consequences of failure be if, let's say, New York went to single payer, but had the same experience California and Vermont had, and it just didn't work? Given your experience in Vermont, how would that be used given the political divide of those people who will fight tooth and nail against that system if we can't do it in a state? And what are the problems a single state would have as opposed to if the nation went that route and you could spread those out and have everybody in as opposed to one state?
Mm-hmm. Well, there's a lot in that question. I guess what I would say, 2020 is going to be here tomorrow, and so we are already in a presidential campaign, and so we're going to start to hear about a national, I think, we're going to start to hear about a national Medicare for all type of a system as part of that Democratic platform. So I think we're going to already have that state, national conversation. I think that, I think it's possible that New York could pass a single payer bill. It's not going to create a single payer bill. I mean, it's not going to create a single payer system, certainly. I think what all it could wind up doing would be creating a process to embark upon further study. But it would be beyond irresponsible to try to make immediate tax changes without proper study, and Vermont didn't do that either. And again, that's why they had the idea to do the exchange first as kind of a warm-up, and they were doing studies and creating the benefit package, and they created the 5-member Green Mountain Care Board. They had to appoint them, get them all up to speed. They put hospital budgets underneath the Green Mountain Care Board. So it took a couple years of warm-up for them to actually even put a structure around something as concrete as a benefit package. And then when the exchange happened in 2014, that's really when the wheels started to come off the bus, so to speak. So I can't imagine that New York would do anything more than an intention to create a single payer system with studies to go along that and then see what happens then. And that gives you lots of bites at the apple. And then toward that, when I was the head of the Vermont Association of Hospitals and Health Systems, and I faced my board again. Once Peter Shumlin was elected, I had to say to my board, if you want me to stop this bill, it's going to run us over like a train. They have the votes, it's veto proof, it's going to pass. So what we were able to do was put in some of those studies that we wound up calling them toll booths, and which would require independent analysis to look at what do physicians think about it, what would change in the workforce, what would happen to quality and patient safety, what are some of the new ideas around delivery system reform that were happening elsewhere across the country that perhaps we could adopt in Vermont. So it required study and analysis. And then the final one was the economic study, which did pinpoint by income level who was going to pay more and who was going to pay less. And again, even with that, and this is where, again, the lesson of, timing is everything and political context is everything. 90% of Vermonters, even with that economic study, would have paid a net of less when you take away their premiums and factor in a state income tax. 90% of Vermonters paid, either close to the same or less, but 10% paid a lot more. And so and again, like the Rand report, when the governor, I think, recognized that his tax base, the greater your income level, the greater your mobility. And so for his high income tax payers, they would move. So, and he realized that and I think pulled the plug.
How do you create the situation, though, that you were talking about to get people on the journey without the political ramifications? I mean, you see it in New York. The health exchange in New York wasn't created by statute. The Senate wouldn't pass it. We all forget that now because we have a very successful health exchange. But the governor did it by executive order, so it could be gone tomorrow if the administration's ever changed. Likewise, you said Governor Shumlin ran into political things. Even President Obama. We all look at ACA now as sort of like the middle of the road proposal, but if you would have talked to people 5 or 6 years ago, either the world was on fire and socialism was here, or nothing was right. He ran it, and by the way, he lost the House and the Senate because of it. So there's clear political ramifications for change. By the way, that's why Democrats haven't, FDR left that out of the New Deal healthcare, and it wasn't until Johnson. How do you create the environment where you can have a discussion about single payer? And I know Bill Hammond and others are here, where you have a broad section. How do you look at the data and say, this is how we get at some of these issues, but give some cover to people who said, we're not going to take a chance on this because we see tsunamis come one way or another. By the way, President Trump ran into the opposite tsunami, I think, in this election, where the Democrats finally ran on the ACA, which was like 5 years ago, no one ever would have thought about that. But once you get a benefit, you don't want to give it up. It's like you see people with the signs, get government out of my Medicare, which I always find is a hilarious statement. But how do you create that environment where you can have these sort of discussions where they're not people just worried about the politics of it?
Yeah, great question. And I think, Jim, you're right. I mean, you see healthcare being passed back and forth, and I think when the Republicans took over the House and they were going to do repeal and replace, I'm like, have at it. You want to own healthcare, you're going to come to regret it, and they have come to regret it. I think the only way to start to do that, I mean, one of my favorite sayings is you build trust by doing good work together. And you have to have a bipartisan something, whether you want to start as a commission or you have to reach across the aisle and make it both a two-party endeavor. You're not going to have, and again, if I have said it 20 times, nothing is cheap, easy, or quick. So solutions have to be sustainable. They have to last more than an election. And I can't even begin to fathom how many billions of dollars we have wasted by repealing and replacing Obamacare, using executive orders to undermine, just to go in a different direction, and people have lost coverage, and I'm sure I don't know the details of it, but I'm sure health plans have spent millions, if not billions, of dollars racing to catch up with, you know, the subsidies they're not getting, the rules that are changing, and how they have to continue to provide a benefit and figure out how much they're going to charge for premiums the next year. I mean, it's been a terrible world for them at great cost to all of us. So we've all been whipsawed back and forth in the political football game. So I don't have a magic answer other than I think it has to be bipartisan and it has to be fact-based. And I think the expectation for the public is that they, you know, that the group would work on a rank-ordered list of priorities and be transparent and try to make progress over time, knowing that again, what the Jeff Bezos and Berkshire Hathaway did is they said, well, we have an intention. We're going to try to figure out a new way to deliver healthcare that's more affordable, and again, even though that's a closed system, they're all self-insured, gigantic self-insured employers. We're going to be in our own little bubble, and we're going to figure out and redesign healthcare. And then as soon as I made the announcement, they're like, give us a few years. So, because it's not, you know, it's not easy. So I just think we have to just start somewhere. Bill?
Hi. Going back to Vermont, how close did Vermont get to creating a reimbursement methodology? And what did it look like? And what was it based on Medicare?
Yeah.
And how did the industry feel about that prospect at the time?
Yeah, until they didn't get very far by 2014, the whole notion generally was that hospitals would be placed on global budgets, and it would be based on the last full budget year that they could calculate, the last closed cost report year. So they'd figure out a base year, and then they would trend it forward, and then there'd be a true up. So that was as close as they got on hospital payments. On physician payments, they knew that they had to increase payments, but it was and the idea was that the money would come from savings and slower hospital growth. So that was as far as they got. But now, under the all-payer model, they have developed, and I don't know the details of it, but they have a total cost of care methodology that goes beyond hospital. It's really like a full cap kind of a payment. And again, I'm not exactly sure how it's administered, but I think they've made a lot of progress on payment methodologies since single payer was off the table. Yes. Oh, I'm sorry. Hi.
Hi. I have another policy realm question.
Okay.
I come from the world of innovation and entrepreneurship.
Oh, good. I will be talking to you.
Okay. I've actually worked with a lot of innovators, entrepreneurs, and investors who are developing these disruptive technologies like ICU in your own home, which could really improve the productivity, lower the cost, and improve the accessibility of healthcare. The problem is the industry is impossible to go into. You're not selling to the consumer. You have to get doctors and healthcare providers on board. You have to get the insurers. It's full of saboteurs and regulations. And the runway to seeing profit in the healthcare industry is over a decade. So no one wants to go in there. What can the industry do? What can policy do to bring these technologies to market and change healthcare?
I don't know a specific answer, but I do think a partnership. I mean, I think that, again, that's part of my point around embracing innovation, is that we should be embracing innovation rather than everyone, and again, part of this has been historic, but, and I think part of it, again, in my bias, has been based on payment methodologies, but we've developed a lot of silos in healthcare, and we still are very fortress-like in that regard. And I think the industry is now opening up to embracing technology and embracing partnerships and piloting. You can't do a nationwide experiment right off the bat. You have to pilot things. So starting small and dreaming big is important, but you have to have partners in order to do that. And I think the industry is moving forward, and I think certainly we are very much looking in a very different way about partnering with companies and technology to help our members figure out what does that new future look like. How do we how do we lower prices or deliver care in a different way that can help consumers and help the industry evolve. And one of the things that I was talking a little bit about scenario planning before with our members, and part of that process is that rather than create one future and try to predict the future, we went through a process where they actually created 4 different futures, again, based on the poverty driver and the technology driver. And one of the realizations that our members came to was that even under, and the scenarios kind of range from doom and gloom to what I called nirvana, where there was no more poverty, technology was available to everyone, and it was just, the sun never stopped shining, and it was all perfect. But even under that perfect scenario, our members recognized that hospitals could not stay the same as they are today. They had to change. So I think that cultural realization that the world is changing quickly, and rather than try to hang on to what they have, rather embrace and look at how do we make progress in the future is something that they all wound up walking away from. And in that sense, the process was very good for them. Didn't give them any quick answers, but I think attitudinally, I think it helped them to think differently about the future. Yes?
You touched on so many good points. And Jim, to your question, how do we get to where we maybe need to be as a nation? Well, first of all, think about the way we fund the political campaigns. It may sound overly simplistic, but we have a federal, any government system just about, right? Procurement is based on competition. That's a foundation of government. Doesn't include prescription drugs in Medicare Part D. You're prohibited by law, the government is prohibited by law for negotiating drug prices. Not true with the Veterans Administration. For some reason, they were given an out, and they get a much better rate for their drug prices. Schenectady County decided to buy their drugs from Canada, which I think is in violation of federal law, but they do it anyway. And they've saved millions of dollars, a small county like Schenectady. So I think some of it is, why is Medicare Part D structured the way it is? I think you know the answer to the question. Secondly, public education is so important. When they were trying to pass the ACA, I was in Washington visiting my daughter. I wasn't there. And I was on the Hill. There was a demonstration going on. And there were a group of people who were holding signs, protest signs, that said, "Don't touch my Medicare," and "Down with socialism." Now, if you think about those two things, and I walked up to one of the guards, the Capitol guards there, and I said, "Look at the ignorance, that's displayed in this crowd." And he said it was a lot worse yesterday. So I don't know what went on yesterday. But I think a lot of it is public education. And, Medicare and Medicaid didn't happen overnight. It took years and years. And you mentioned President Roosevelt. Harry Truman pushed very hard for national health care. The timing was off. And you mentioned the timing is very important. Mm-hmm. We may be approaching that time because people are getting fed up with the costs, with the increases, with the lack of health care, the access to primary care physicians. Not just a problem in Vermont. It's a problem nationwide, especially in rural areas. So I think there are a lot of things that may come together over the next decade, but I think you're absolutely right. Timing is so important, but these other things have to happen as well.
Mm-hmm. No, and believe me, I don't think that we're going to not have any disagreement. As I said before, it's messy, it's not perfect, it's not linear, but I do think it's important to have goals that stand the test of time, and that people can begin to, over time, to coalesce around. May have disagreement on the tactics, but again, we've talked to the administration about this. I think the state is doing a lot right. They really are, and I think some of it is just packaging, and then tweaking how they're investing on certain things. So, but I think that we have a good foundation here in New York. And again, when I talk to my counterparts from around the state, like Mississippi and Arkansas, they recognize that New York in some ways is a very tough state, but they're like, I would much rather have your problems than the problem of where they have Medicaid eligibility is at 100% of the federal poverty level. And they have, literally a majority, many of their citizens have no access to health care. They don't, forget coverage, they don't even have access to there's no physician in their county. So they have no access to care, which is, something that I think we ought to talk about too, is like if you're wanting to improve the health of the population and coverage is not politically possible and we can't cover everyone, then what about making sure people have access to care and making sure that we're looking at hard to serve communities and figuring out how we provide care to them? Because again, that investment will reap benefits over time. Not in 2 years, not in 4 years. Even a lot of the work that we did in Vermont, even before single payer, was around chronic care and how do you improve the delivery of chronic care as a way to reduce health spending growth. And surprise, surprise, we found that health spending growth increased in the first 5 years before it would start to decrease, because you have people who are compliant and you're spending more on prescription drugs because they're compliant. They're actually managing their hypertension, they're managing their diabetes. And so your spending increases over time, and then you see a reduction in admissions and readmissions over time. So again, the facts are important, and you have to really put them out there, and then again, prepare for it. Otherwise, you want to give up.
Let's give Bea a big round of applause for her. We literally could keep you here for hours because of your depth of knowledge, but we're going to put this online so you can watch it again. If you have questions for Bea that you think of afterwards, please email them to us or someone at HANYS, and I'm sure she'd be glad to answer it. We'll be doing more of these health forums over the next couple of months, so thank you, Bea, for kicking this off, and thank you for coming through the snow today. Thank you very much.